In patients with Sjögren's disease, neurological symptoms precede the diagnosis at a 2-to-1 ratio. 2-to-1. The nervous system was already being affected before most patients even had a name for what was happening to them. If you have burning pain, tingling, brain fog, or balance problems, and no one has connected that to your Sjögren's, this video is for you. My name is Dr. Carol Wada. I'm a quadruple board certified allergy, immunology, lifestyle medicine physician. I also live with Sjögren's disease and dysautonomia. So when I say that I understand what it feels like to have neurologic symptoms that nobody connected to the diagnosis, I really mean that from both sides of the exam table. Today, I'm walking you through what the research actually shows about Sjögren's and your nervous system, what symptoms to name, what to ask for, and what the 2025 clinical practice guidelines now say your care team should be doing. This one is worth saving before your next appointment. Now, a quick note, this is all for educational purposes only. You need to be working with your team of clinicians. I'm going to be sharing patterns I see clinically in my practice and what the evidence supports broadly. Let's get into it. Before anything else, I want to give you a number that reframes this entire conversation. In one central nervous system cohort study, 64% of Sjögren's patients had neurologic involvement as their first manifestation of the disease. Not dry eyes, not dry mouth, neurologic symptoms. And in patients with dysautonomia, meaning the autonomic nervous system dysfunction that drives POTS, dizziness, GI problems, sweating issues, bladder issues, the dysautonomia preceded the Sjögren's diagnosis by 2 to 10 years in most patients in one published series. The nervous system was being targeted years before anyone connected the dots. So, what does this nervous system involvement actually look like? All right, let me explain what is actually happening, because once you understand the mechanism, the symptom picture makes a lot more sense. Now, Sjögren's targets the nervous system through several overlapping pathways. The one I want to start with, because it explains the most symptoms, is what happens to the sensory neurons themselves. There is a structure called the dorsal root ganglion. It is essentially the cell body of your sensory nerves, the neurons responsible for pain, touch, temperature, position sense. In Sjögren's, the immune system can send inflammatory cells directly into these ganglia and can begin to damage them. The result with this is a sensory neuropathy that does not follow a typical what's called stocking glove pattern that you would see in situations like diabetes. So in diabetes, often the hands and the feet will be a pattern that you will see pretty commonly. When the dorsal root ganglion is involved, the symptoms may be a bit more patchy and not follow that more typical distribution. It's also considered non-length dependent, meaning it can involve the face, the trunk, the proximal part of your limbs, so the upper arms or upper legs, areas that most neuropathy workups are not typically looking for because they're often looking for the more common or typical pattern. The second pathway is the autonomic nervous system. Up to 55% of Sjögren's patients have autonomic dysfunction on formal testing. That is significantly higher than matched controls. This is the system that runs your heart rate, your blood pressure, digestion, bladder, temperature regulation. And when it is dysregulated, the symptoms can show up as something like POTS, orthostatic hypotension or intolerance, GI dysmotility, meaning that you may be pooping all the time or not at all, or you may have urinary urgency, frequency, other symptoms related to bladder function. I also often will hear that patients will have a change in their sweating patterns. They either don't sweat at all anymore or they are sweating constantly. They have difficulty with temperature intolerance. All of these are common, and all of them often get frequently attributed to something else. The third pathway is in place that this can affect us is the brain itself. The central nervous system involvement in Sjögren's is estimated at 2 to 25%, which is a pretty big range, but it depends on how you look for it. When patients are systematically assessed with neuropsychologic testing and neuroimaging, cognitive symptoms, the fog, executive dysfunction that can look and feel a lot like ADHD, word finding problems, they're found in about 67% of patients. It's not anxiety, it's not aging, it's the immune system and the chemical messengers that the immune system is using to communicate with one another that's affecting the brain and the nervous system's terrain directly. So let's talk about 7 symptoms that are worth knowing the names of as you go into your next visit with your clinical team. This is the section I really want you to save because the 2025 clinical practice guidelines from Arthritis Care and Research, which were the first formal guideline ever written on peripheral nervous system manifestations in Sjögren's disease, is pretty explicit about which symptoms should trigger a neurologic workup. So here are 7, you can write them down. You can bring this list to your next appointment. Number 1 is burning pain, tingling, or numbness, especially the one that does not follow that typical hand and feet or stocking glove distribution. If it involves the face, the trunk, your upper arms or legs, lower legs, that is a pattern to name specifically. Number 2 is facial numbness or tingling. Trigeminal sensory neuropathy is one of the most common cranial nerve areas of involvement in Sjögren's. It is often universally missed. It can show up as facial pain. It can look like headache syndrome. The trigeminal nerve or cranial nerve 5 affects our face. And so this is a really important one to know about and to be able to name. Number 3 is sensory ataxia or balance problems that are not explained by the inner ear issues. If you feel unsteady and a typical dizziness or balance workup came back normal, especially when it came to evaluating your inner ear, sensory ganglionopathy should be on the discussion table. Number 4 is orthostatic intolerance. This is what I deal with primarily. This is the dizziness that you can experience upon standing. If it's accompanied by a racing heart, that may click it over into POTS territory. This can be accompanied by near fainting and in some cases actually passing out. If this is happening and no one has connected it to your Sjögren's diagnosis, you can ask specifically about autonomic testing. Often, sometimes tilt table testing will be recommended. There also are some more easily available options, including doing orthostatic vital signs, meaning just taking a blood pressure and a heart rate as someone goes from laying down to sitting or standing up. But this needs to be done with some help because we certainly do not want someone fainting, passing out, getting injured from this evaluation process. Number 5 is cognitive dysfunction that's disproportionate to your age. Subcortical, meaning in the brain, executive dysfunction and verbal memory impairment are present in up to 44% of Sjögren's patients when they are formally tested. So what does this mean? It's a lot of fancy words. If you have brain fog and it's being misattributed to depression or aging, this is some reasoning that you can push back against that. Number 6, unexplained headache, particularly migraines without aura. Migraine is the most common CNS symptom or central nervous system symptom in Sjögren's, and it presents in 47% of patients in one series. And almost never is it attributed to the underlying autoimmune process. I am fortunate. I have had a history of some headaches that have come and gone over the course of my life. And since being on treatment for my Sjögren's disease, I have noticed that these are a rarity as compared to how often they may show up in my 20s and 30s. Number 7 is asymmetric sensory loss. If numbness or burning is more pronounced on one side of the body or in a patchy distribution that, it's not like a match from one side to the other, that's a specific red flag for the type of nerve involvement that is most characteristic of Sjögren's disease. So why does this keep getting missed? Here's the part that I think is really important to say out loud. Half of the 4,050 Sjögren's patients surveyed in the 2026 international study felt that their neurologic symptoms were underestimated by their healthcare providers. Half. And in a landmark series of patients with CNS Sjögren's, every single patient had met criteria for a definite multiple sclerosis concern before the correct diagnosis of Sjögren's was made. Every single one had kind of this misdiagnosis or this concern for, this is MS, before it was figured out to be Sjögren's. The documented misdiagnoses before Sjögren's include a whole list of possible other diagnoses that can affect the nervous system. So some other diagnoses that were made prior to the final diagnosis landing on Sjögren's included MS, as we just mentioned, or multiple sclerosis, fibromyalgia, functional neurologic disorder, anxiety, and in some cases, conditions as rare as Creutzfeldt-Jakob disease. The mean diagnostic delay, so the time of when symptoms started to when the diagnosis actually was made for Sjögren's overall, is approximately 6 years. But when neurologic symptoms are the presenting feature, one case series documented an average of a 15-year delay. This is not because the symptoms are subtle. It is because the connection is not being looked for, the connection between Sjögren's disease and neurologic symptomatology. And that is exactly why you need to be the one in the room often to name it, because this connection is not taught and it is not passed and talked about amongst physicians caring for patients with Sjögren's. So I want to take a quick pause, because if what I'm describing is part of your picture, the 5th annual virtual Sjögren's Summit this July is exactly where this conversation continues. Stronger with Sjögren's includes world-class experts, a new era of treatment, real tools for the full Sjögren's picture, including the neurologic dimension. It's virtual, it's interactive, it's free to attend live. Registration is now open. The link is in the description, and gosh, I'd love to see you there. Okay, 3 things to do with this information today. They're concrete, they're doable. Hopefully you can do them this week. The first is to name the symptoms from that list of 7 at your next rheumatology appointment. So make that list, have it ready for your next appointment, even if it is, a ways out. Don't describe them generally. Say, I have burning pain that is not stocking glove distribution. I have facial tingling. I have what I think is orthostatic intolerance. That specific language matters because it cuts to the chase. It tells your doctor a bit better what diagnostic pathway they might need to consider. The second is to ask whether a formal neurologic evaluation has been considered as part of your Sjögren's care. The 2025 clinical practice guideline is something available that you can reference by name, and it recommends a systematic neurologic assessment for Sjögren's patients. Most have never had one, and most rheumatologists, because this is a new clinical practice guideline, haven't integrated this guideline into your routine care at this point in time. But naming it helps change the conversation and it brings it back to the table. The third is you can ask specifically about the possibility of getting a skin punch biopsy to evaluate for small fiber neuropathy, especially if burning pain or tingling is part of your picture. It's a minimally invasive outpatient procedure that can confirm small fiber neuropathy, which is the most common type in Sjögren's. It's a test that most patients are never offered because the standard nerve conduction study may often come back normal, but normal nerve conduction does not rule out small fiber neuropathy. Another test that can look for this is something called a QSART. These 2 tests, the EMG or nerve conduction study and the biopsy in QSART, look for different things. All right, before I send you anywhere, I want to say this. If you've been living with burning, tingling, brain fog, balance problems, and no one has connected it to your Sjögren's, it is not you being dramatic. It is a documented gap in how this disease is evaluated, managed, and taught. The research says your neurologic symptoms may precede your diagnosis at a 2-to-1 ratio. And the guidelines, which are brand new, say systematic neurologic assessment should be a part of your care. Half of patients in that 4,000 person survey felt their providers underestimated these symptoms. So you are not wrong, and we're not wrong to keep pushing. The system just is not making the connection, and it's not necessarily looking in the right place. Here's what I want to know from you, and I genuinely read these. My team helps me, brings them to my attention too. Have any of your doctors, your rheumatologist, your neurologist, your primary care doc, ever connected your neurologic symptoms to your Sjögren's disease? I'm curious. Drop it in the comments, because that answer matters for every person who finds this video next. If this video gave you language that you did not have before, please save it. Keep it handy before your next appointment. Send it to someone who's been told that their symptoms are burning and tingling, all those things are just related to their fibromyalgia. And if this kind of content helps you, subscribe. This is exactly what this channel is for. New videos every week, science-backed, a little bit of fluff sometimes, but until then, I will see you in the next one.